All right. Hi, guys. I'm MD2.
I'm MD3.
And we're here today to talk to you about needle decompression uses and really kind of what the protocols state and where we should really consider using them.
So needle thoracostomy, as it were.
Yeah. I think it's a great tool to have in your toolkit there. And I had a medic actually ask me recently when our protocols really dictate it, and I don't know if it's necessarily set in stone, but I consider a needle decompression in any cardiac arrest that appears respiratory. One of the things that we've learned throughout the fellowship is when you're out in the field, things are loud, and it's hard to sometimes necessarily accurately hear stuff. So if you've got a patient who's in PEA arrest or asystole, and you think there might be a chance, and putting a needle in is a good way to kind of cross your T's and dot your I's, as it were.
Well, it's definitely one of the causes of cardiac arrest, right? But I'm not sure if I would go as far to say it's for all cardiac arrest, right? I mean,
right.
You have respiratory complaints at known COPDers,
right.
Known recent COVID patients, really bad CHF. Those patients I wouldn't do it on, but you're doing it really because you're trying to evacuate any sort of air between the pleural layers, right? And so what are the high-risk patients that might have a pneumothorax?
So I consider this in anybody I see tall and thin, if there's any signs of trauma on the chest. So we all have those elderly patients who fell at home and don't necessarily, they're like, I don't want to tell anyone, but then you're ripping off their shirt and you see bruises from when they fell and hit their cabinet, 3 days ago. And you can, even from a slow leak, you can get a tension pneumothorax. You get so much air in that side or whatever side the lung is on that the heart can't fill with blood, and then when the heart can't fill, it just stops beating. So your goal is to temporarily let that air out until you can get them somewhere where they can get like a chest tube or a definitive way to continue to suction the air out. So those are the ones that I tend to look for. Do you have any other?
Yeah, I mean, I think obviously the cardiac arrest, you're throwing everything out at it, and I think that those are all good points to consider doing a needle thoracostomy. The other one is obviously the, younger, slender, tall white male who is also in very severe respiratory distress. If you really truly feel like you clinically have signs of a tension pneumothorax, right? You can't hear anything on the one side. You're starting to see JVD. There's no other reason it may be, and they're starting to become hypotensive. I mean, you're kind of then teetering on that definite clinical diagnosis of tension pneumothorax, but you definitely got to be very, very confident in that setting before you go doing a procedure that, is dangerous, right? So speaking of the procedure, there's kind of the anterior approach and lateral approach. Mm-hmm. You want to talk about each and kind of what your thoughts are on both of them?
Yeah. My personal favorite is the lateral approach, so I'm going to save that for the second half. But the initial approach that I think most people are taught is the anterior. You kind of go in the mid-clavicular line between the second and third spaces. It's nice because it's easy to find. We're often in positions where you're doing compressions in a tight space, or even in the back of an ambulance. Sometimes there's not room to get somebody's arm moved out of the way, so you've got the target and it's easy to go. You take a 14 gauge needle, you put it in above the rib. You're not going below because there's a lot of nerves and vascular tissue you can hit and cause more harm than good. You basically go until you hear air, and then you pull the needle out and let the air come out and decompress, as it were. The other way to do it, which I'm a bigger fan of because I feel like it doesn't involve as much measuring, you're not really feeling around, you put the patient's arm up on whatever side you're on.
Before we move up to your lateral, because I agree, I think lateral is the way to go. But the anterior approach, when you say mid-clavicular, one of the things always is it's more lateral than you think of mid-chest, right? I mean, because the clavicle actually lies a little bit more lateral than you would expect. Yeah. So it's almost kind of, I'd say almost 2/3 lateral, because you're really trying to avoid
in the actual middle of the clavicle,
middle
not
of the
in the
clavicle.
Middle of the chest. It's exactly. A good point, and I think that also leads to one of the rare complications of the anterior approach that I didn't mention. But if you go low enough, there's the aorta sits here, the rest of the heart, and so if you're too medial, you're too close to the midline, and you're too far down, you can hit structures that you really don't want to hit.
Yeah. So the mid clavicle doesn't mean the midway between your manubrium and your AC joint here. You're kind of more lateral, especially on that left side. So just a little point on the left-sided anterior approach.
But on to everyone's favorite, the lateral approach. If you're going to needle decompress from the lateral approach, your goal is to take the arm up, and you're going to go right about where the armpit hair stops. You can measure up and say third and fourth and fifth intercostal space, but again, in the thick of it, we have some patients that have body habitus that makes it hard to feel exactly where the rib space is. But what you're doing is you're looking for the armpit hair stops to help make sure that you're high enough. Because if you go too low on this side, you run the risk of hitting the liver, and this side, you run the risk of hitting the spleen or even the stomach. And I mean, that's a pitfall we see even in the emergency department. We teach all of our interns when we're teaching them how to do chest tubes the same thing. Don't go too low. You're also out of the way of those big vascular structures you might hit in the front. And then the other benefit is that when they go to convert it to a chest tube, they already have a tract that they kind of know where you guys went, and they know where to go for their definitive chest tube placement.
Yeah, or at least how much room they have above and below the diaphragm. I personally, I mean, I agree. I prefer the lateral approach. I like the armpit hair localization. The classical teaching is the nipple line of the inframammary fold. But I find that those can be pretty low, again, especially because of body habitus. So I usually find what I think is the right one, and then we'll go one rib space up. That way I give myself a little bit of leeway there. And that way you're not close to the diaphragm, because you definitely don't want to be low.
Not a bad move at all to go one space up, because there is, even though even like I said, like kind of like Dr. Thomas was saying, even though they say between the fourth and fifth space, you get a little bit of wiggle room going up, and you can kind of go higher than you need to. So needle decompression, there it is. It's one of those procedures that it's kind of, you've got to do it to get comfortable with it. And it is, in the case of an arrest, it is very much, I think, a Hail Mary.
Yeah.
But there are indications clinically to use it too. If you've got a patient with chest trauma and their blood pressure's tanking, but they're not bleeding out of anywhere, and you don't hear breath sounds in the right, and you see the trachea is no longer in the middle. And I know you mentioned JVD earlier for people who may not know, because I didn't know until probably halfway through med school. It's my embarrassing admission here, but JVD is jugular venous distension. So you'll see people who look like they're bearing down even though they're not, and they've got, this huge jugular vein, and you're like, well, so something's really going wrong.
Definitely.
So,
well, I think that was a great review of needle thoracostomy. If anybody has any questions on any of that, happy to ask. We're happy to answer.
Agreed. All right. Take care until next time.